Hello everyone, this is Neha Pellegrino, Senior MSP Compliance Counsel, and I wanted to take a moment to welcome you to the ECS on MSP podcast. As you all know, ECS is dedicated to assisting you navigate all the complexities of MSP compliance, but we believe that compliance shouldn't be static. The rules evolve, technology evolves, and the way people consume information evolves, which is what led us here. While we've been continuing to connect with you through our monthly webinars, which we love providing, we recognize that this industry moves really fast, and so do the professionals working in it. So the idea behind the podcast is about meeting you where you are by delivering content in a way that fits your schedule. And we're really excited to have this be a part of our ongoing commitment to share knowledge and support you. Each episode will bring you practical insights and real-world discussions, all in a format that's easy to listen to and easy to learn from, almost like you're sitting on the couch in our office. So whether you're here to stay compliant, deepen your understanding, or just hear from the voices that live and breathe this work every day, you're in the right place. That being said, let's get started.
So we have some great presenters today wearing green and being very festive, including Marty Cassavoy, our Senior Vice President of MSP Compliance and Business Development, Scott Huber, our Senior Vice President of Technology, and Ms. Neha Pellegrino, Senior MSP Compliance Counsel. And all right, I'm going to turn it over to Neha to get us through today's agenda.
Great. Thanks, Adriana. So I also just wanted to say happy St. Patrick's Day to everyone. I think for the few of us up here in the Boston area, it's practically a civic holiday up here. So we appreciate you taking a little bit of it to spend some time taking in some MSP compliance along with your green beer today. So for today's session, we're going to start where else but from the beginning and talk about how we got here. Over the last few years in particular, the MSP space has seen some pretty transformative changes that impact all aspects of how we operate. So we'll dive into some policy and procedural changes surrounding Section 111 reporting, what changes we've seen as far as Medicare set-asides are concerned, and finally, opportunities on the horizon for improvement. So as we jump right in, I'm going to hand the mic over to Marty to set the stage on what's led us to where we are now.
Sure. Yeah, no, thanks a lot, Neha. So certainly, where we, looking at the last really 5 years, 6 years, going back to, I think it was right around, COVID, we started to see some significant changes with the way that CMS approached things. And certainly with the way that CMS looked at the data that was coming into it. So just from setting the stage in terms of context, you're looking at really tens of thousands of claims that are reported to CMS every single year via Section 111. So we're looking at whether it's tens of thousands of TPOCs on liability cases, ORM reported claims on no-fault claims, and certainly ORM on workers' compensation claims. We're seeing really significant data that's going to CMS, and there's an admonition, certainly now more than ever with the latest administration, from the for the government to really start to utilize that information in a way that is hopefully going to have impact in a positive way, right? Well, and they have to use the data. That's the information that they're receiving that at all levels of CMS, right? So they have to make data-supported, data-driven decisions, and this is something that didn't just start in the last administration or this administration. It's been going on really since for the last 6 or 7 years. Now, when we look at that, we think about what that means, right? Every decision when it comes to MSP comes into one of two different buckets. Either it's a decision that CMS has to make with regard to coordination of benefits, which is payment prevention. It's the old payment, an ounce of prevention is certainly worth more than a pound of cure. So CMS really subscribes to that philosophy, and they really always have, and that's driven by the law. The law requires CMS to do that, right? The other one is recovery. So everything that CMS looks at is if it can't prevent payment, then it has to get its money back. And over the course of the last it's really 10 years, but certainly, especially the last 5, we have seen a ramp up in recovery efforts by CMS and it's had impact to everybody. And we see this on a day-to-day basis, right? So you think about if you're handling a no-fault claim and you get an individual who's contacting you and saying, hey, please help me out. I'm having trouble getting treatment for this completely unrelated personal medical condition. And they're saying that it's because I had a car accident or a workers' compensation claim that probably closed 10 years ago. They're contacting you and saying, hey, I can't get coverage here. Well, that's because there's probably a mistake or misunderstanding between somebody, whether it's the provider, whether it's CMS, et cetera, whether it's you, as to coordination of benefits, right? Or as to claim information that's leading to improper coordination of benefits. So the key objective of absolutely everything CMS does is one of these two goals, right? Coordinate benefits or recover. When we talk about all of the changes that we're going to be discussing today, and there are significant numbers of recent changes, what we want to be looking at and the way that we want to be addressing it is, what is the change? So what does it mean? What does the change mean for you? What does the change mean for the attorney involved? What does the change mean for the individual claimant and CMS, right? What's the impact? Who's impacted by it? Are you impacted by it and nobody else? Is everybody involved impacted by it? Some of these changes have absolutely no impact whatsoever to the beneficiary, other than the effect that the change has on the beneficiary. Others of them, the beneficiary has to know about this stuff as it's happening, especially when it comes to Medicare set-asides. And that's where it comes in, who's impacted, right? Ultimately, everybody involved here is impacted, even you, even if you're not just as a taxpayer, you're impacted because of the fact that there's, from CMS's perspective, hopefully improved coordination of benefits and recovery. With all that being said, we know that there are a lot of challenges with these changes that CMS has introduced. And so the goal of this presentation really is to try to, in this conversation more than anything else, is to try to summarize all that, to put it all together, to try to give you the information that you need, not only to remind yourself of some of the changes that have occurred, but then also to take advantage of them, right? Because we're going to cover some of these changes in a way that you can take advantage, way that you can improve, hopefully, your organizational performance and your own individual performance when it comes to handling cases involving Medicare beneficiaries. And when you can do that, when you can hopefully terminate ORM a little bit earlier than you may have otherwise realized you could have, right? Or when you can take advantage of something like, we're not even going to cover it today, but the fixed percentage option, right? Where you can just directly resolve a conditional payment matter for on a $9,000 settlement in a way that you couldn't have a few years ago, right? So those things improve the ability for you to quickly resolve your case, and also makes it so that it helps the beneficiary out a lot faster. So that's really the goal here, and we're going to walk through them. And as we do so, Neha is going to go ahead and get us started on the next slide.
Great, thanks, Marty. Yeah, so we're just going to start running down some of the political policy and technical changes that we've seen in regards to Section 111 reporting. So start with the first one on this list here, civil money penalties. In January of this year, CMS held a webinar reiterating the final rule for CMPs as far as how CMS will administer CMP audits, the communication process, and what REs can expect if non-compliance is identified. So main points were, confirming that the first audits will occur in February this year, that the agency would randomly select 250 records, and that CMS expected the first notices for possible CMPs to be issued in March. So right now, right? Although it was made clear that reporting volumes can fluctuate by quarter, making these projections on timing somewhat unpredictable. So if we go into number 2, sort of in the same vein of talking about the final rule, a delay in the enforcement of CMPs was proposed. So CMS stated that it will not assess penalties for any late reported workers' compensation claims until July 2026. That is for any claims reported late as of July 2025. Now, the policy behind this was due to the implementation of the work comp MSA reporting requirement, right, which was effective April of 2025. So this grace period is intended to allow RREs additional time, specifically, one reporting cycle or 1 quarter to adapt to, both the technical and operational changes associated with the mandatory reporting procedures. So if we can move on to number 3, which is TPOC clarification. So an area where CMS provided some clarity came from an updated NGHP user guide in terms of how to report TPOCs where there are either multiple dates of loss or multiple settlements. Now, there were a lot of questions surrounding this topic, and there still tends to be a lot of confusion in that the method that has been laid out is not always, the one that seems to make the most sense. But what we can take away from the direction that's provided, and Adriana, if you want to just move to the next slide, we have some language directly from the user guide as well as an example. And this is exactly where you have a single settlement with one RRE resolving multiple dates of injury. So here, the direction that we were provided is that the RRE should report the earliest date of loss with the total TPOC amount encompassing all dates of loss. So if we can move to the next slide, we have another example of a slightly different situation where you have multiple settlements with the same date of loss, but you have different RREs. So here, each RRE should report its own TPOC amount, not the aggregate that the Benny receives. And the user guide indicated that the same guidance would apply to the reporting of MSAs, the same as it does to the reporting of TPOCs. I think we can move back down the slides to get back into our rundown here. It's being weird. Is my audio good?
You're back.
Okay. Awesome. Thank you. All right. So we were on number 4, denial of benefits. So in May of last year, CMS released a notice, which was essentially a pamphlet via the Medicare Learning Network, or MLN, which was bluntly titled, "Don't Deny Services and Bill Correctly." So this alert announced in no uncertain terms that providers are not permitted to deny medical care to beneficiaries. So it even laid out procedures that providers should follow if they believe there's an open claim for the conditions the beneficiary is seeking care, as well as additional information about billing when the beneficiary has a Medicare set-aside account. So the goal here was really to provide a roadmap to ensure that individuals are not hindered in receiving medical care due to either their beneficiary status or the existence of an open work comp or no-fault claim. Okay, so if we continue down the line for number 5 on our reporting list, I'm going to allow us to hear from Scott as he discusses some ORM triggers.
Thanks, Neha. Historically, CMS guidance had stated that medical payments do not actually have to be paid in order to trigger the need for reporting ORM. That language simply stated that if the RRE has or will have a responsibility for medical treatment, then the claim must be reported with ORM equals Y. Pretty plain and simple. However, in June of 23, user guide added a very key phrase stating when the beneficiary receives medical treatment related to the injury or illness. I'll say that again. When the beneficiary receives medical treatment related to the injury or illness. This clarification was most welcomed by the RREs that offer no-fault coverage because they have tens of thousands of these types of claims where there's an accident, but medical treatment was never sought. So a passenger may have bumps and bruises from an accident. They denied treatment on the scene. They never go see the doctor, but those claims historically would have had to be reported, through Section 111. There was no treatment. They became essentially information-only claims, and would oftentimes result in the beneficiaries being stuck dealing between the provider and the no-fault carrier for treatment that's related, unrelated, to the accident. These claims sitting out there just kind of mucking things up, right? But with this change, the beneficiary must have received medical treatment that the RRE is responsible for in order to trigger ORM reporting. So that was a pretty key benefit to the no-fault industry back in that user guide update in 2023. Next one is rest in peace to the no-inj or no-INJ ICD code. So for the longest time on liability claims, there were situations where a claim may settle, but there was no associated or alleged injury involved. But mental anguish or something of that nature, no specific ICD code would apply. In that, again, June 2023 user guide update, CMS acquiesced a bit on that and have now made that no INJ code optional. Basically, has made it much easier for the industry to resolve those claims that don't truly have medical components, and in turn has allowed claims professionals to focus on the claims that do have related injuries, which is what Medicare really is ultimately concerned with here. Every now and then we come across situations where the data doesn't quite jive with what we see in the user guide. We have a good line of communication to the CMS team. So back in a few years ago around COVID time, our team here at ECS noticed that CMS had created duplicate recovery leads in their system for the same claim. However, the policy numbers were different. So we looked at the Section 111 data and found that for that beneficiary, there was only one Section 111 claim, but that the policy number had changed between the time that it was first sent to CMS as an ad record and later sent as an update. Turns out this was just a typographical error by the claims handler, thinking they were correcting the typo in the data, but downstream, it created two leads at CMS. So in speaking with them, going through all this, we all discovered that a change in policy number is causing their system at CMS to see that as a second claim, or at least a second recovery lead. And in response to that, CMS made the policy number a key field. So we have key fields and important fields. Key fields require that a delete record be sent to remove the offending value or the old value, and then an add record be sent to submit the corrected or new value to CMS. Important fields are just send an update when there's a new ICD code, when there's TPOC, what have you. But being a key field, that's a pretty significant change, at least as far as it pertains to the data flow and claim system processing. So as I said, that first offending value or old value has to be sent as a delete, then the new value sent as an add record so that CMS has the corrected values. How does this apply to you guys? What's the significance? When it comes to normal claim cycle, probably nothing, right? Policy number is going to stay the same throughout the life of the claim. However, this is extremely critical when claims change hands. If claims are moving from one TPA to another, that's where this could be tricky. Formatting the policy number, hyphens in a policy number here or there, changes in any way, shape, or form to those values could lead CMS to think it's a new claim. So it's very important that if that is going to happen, the prior accepted values get deleted through Section 111 prior to the new values being sent as ad records. So if you think this may happen, this may be part of your claims, or you may have something where this may come up, please reach out to us. Our team is highly educated on this, and they can certainly help and assist with that. The Go Paperless initiative, recall that the overarching premise of Section 111 is to inform CMS when a primary payer exists, right? That goes back to the first slide that Marty talked about. So when that claim is submitted to CMS, it initiates a recovery process, and a letter is sent to the RRE stating conditional payments may apply. Prior to 2022 or so, those letters were delivered via good old-fashioned US Postal Service. But with the implementation of the Go Paperless initiative, those letters can now be downloaded through the Medicare Secondary Payer Recovery Portal, or MSPRP, as we abbreviate it. And then throw in the concept of the third-party recovery agent, or TPRA, another great acronym. Both the RRE and the TPRA can opt in for receiving those letters through the portal. It's mutually exclusive. The RRE can do it. TPRA doesn't have to. Vice versa. TPRA can do it. RRE does not have to. But by opting in, those letters can be obtained on day one of publication rather than having to wait any number of days for the Postal Service, to deliver them to your office. Think of the storms that are moving through seasonally, hurricanes, whatever. Anything that could cause a delay in getting those letters would, cause a delay in your processing of those special payments. Marty or Neha, anything to add to all this stuff? Marty, Neha and I did all the talking on this one. What do you got?
Yeah, the thing that I was going to come back to really quick was both regarding number 3 around the TPOC clarifications and then number 4, denials of benefits, right? So TPOC clarification that's been made by CMS, these are clarifications. Some of them, they may be no change to the way that an organization has trained folks to report, but in others, there may be real technical challenges to the way in which CMS wants you to report that claim and the way that you can report that claim. And we've encountered this quite a bit over the course of the last 6 months, especially since CMS announced the their updated, let's call it, guidance with regard to multiple dates of loss settling with one claimant, right? So when it's important to understand that the goal is to report the claim to CMS as a settlement. If you're, for whatever reason, unable technically to report a date of loss on a phantom claim, right? Scott talked about the injury-only claims that were never reported as ORM or should no longer be reported as ORM. Certainly those things would also apply in workers' comp, right? Where you might have a situation involving a person who had a notice-only claim, right? If you may be technically resolving that claim via a settlement that might be being included in a release, that date might be included in the release, making that date, if that was the first incident that occurred for the individual, the TPOC date, that can be not only challenging, it can actually be literally impossible in some systems. So give yourself some grace, give your organization some grace. The goal is to report the claim accurately in terms of the TPOC amount and the TPOC date of loss on that situation, where it's, if you're going to only report one date of loss, it'll all get worked out in the end. As long as you're reporting that TPOC, that's the most important thing, right? Because you want to make sure that you're not creating risk of penalty as you sort of try to figure out which of the dates to report it under. And if you ever have a question about that, then you can certainly contact me or Neha or Scott, or if you're an ECS Section 111 MIR client, then you can contact your MCM and they'll help you out. The other thing that I was going to point out here too is that same thing goes for denials of benefits. I can't tell you how many times Neha, me, or any of our team here really runs into the situation where someone calls us and says, "Hey, help! This claimant is having trouble getting this treatment. They had a back claim in 2020, and they are now having trouble going to this provider who's giving them cancer treatments." A lot of times it is the provider who doesn't understand the data that's coming through the system, right? It really is. That's 100% an actual thing. And it's the provider who's making these mistakes sometimes. In fact, it's probably like 95% of the time in our experience that it is a provider who's misunderstanding it. However, that doesn't mean that it's not impacting the person's quality of life, right? So we do have a process that we recommend that people follow. You can certainly contact any of us or your MCM, and they'll help you to basically provide you with a one-pager on how to resolve these cases, hopefully quickly and expeditiously. But there is a process that we recommend for doing it. It does not always require you to contact CMS. That's what's important. It's not always that you have to contact CMS and make a change. You can sometimes simply do so by providing the provider with the correct information. So how many times am I going to say provider? So those are the two big ones that I think that are important from a practical impact. Those clarifications may have more to do with what goes out from CMS than there's a real change in terms of what you need to do. But your resource is always, our team here who can help you. And I think with that, we're going to go on to Neha, who has the next set of changes in the lovely land of WCMSAs, which is always a fun topic.
Great, thanks, Marty. All right, so Adriana, we can move to the next slide. Topic 3 here. work comp MSAs. Awesome. All right, so let's talk about some of the changes that have transpired in terms of Medicare set-asides. One being mandatory MSA reporting. So we'll start with the first topic here. Effective April 4th of last year, CMS mandated the reporting of MSA amounts on all workers' compensation TPOC. So we're, heading right into the 1-year anniversary of this. This is regardless of the total settlement amount. So this is also separate and distinct from the voluntary MSA review process. So the guidelines direct that alongside reporting TPOC, you should also report the following required data elements regarding an accompanying Medicare set-aside. That is the MSA amount, the MSA term, the whether or not how it's being funded, so whether that's lump sum or structured. And if it is structured, they want to know the seed amount and the annual amount. So the implementation of this process has been a little rocky, I think we could say. The challenge being that CMS appears to have been folding the reported MSA data into its claim system as opposed to simply documenting the data, which has then disrupted the settlement process for some claims. So to provide some context, what many have now experienced is that CMS has been declining to review MSAs when a TPOC is reported before the WCRC has completed its review of the MSA submission. So many of these were because the case settled with a condition subsequent, right? Which being the approval of the MSA, which left the MSA amount unknown at the time. Now, per Medicare's policy, the reference guide does allow for settlements pending CMS review of the MSA. And until mandatory MSA reporting came onto the scene, there really was no issue with, posed with these TPOC reports. So now that TPOC reporting could inadvertently suspend MSA review, it's important to be vigilant, not only about the timing of your reporting, but also the accuracy of the information reported. So what are some things that you can do to mitigate this from happening? First, time TPOC reporting very carefully, right? If you're submitting an MSA for review and approval, only report TPOC after the claim is fully resolved and the MSA has been fully funded. So next, kind of getting a little deeper, depending on, your carrier's internal protocols, you might want to consider a non-submit MSA. These types of evidence-based allocations are defensible, compliant, and avoid the issues that can arise, with CMS review. I think the irony here being that it appears that the intention, for CMS was to be able to capture some of this non-submit MSA data through the, mandatory MSA reporting requirement. But this is a topic that, is evolving as we speak. So as a matter of fact, we would implore you to, join CMS's upcoming webinar that'll be held next week on March 25th, I believe. And that webinar is supposed to specifically address, work comp MSA reporting best practices. So if anyone's actually looking for a link to that webinar, you can find it within our latest blog, which is Michael Flower, and it's posted to our webpage at examworkscompliance.com. So let's move on to the second topic here. Another policy change that we saw last year involved $0 MSAs. That being effective July 17th of 2025, CMS halted its review of MSA proposals with a $0 allocation. So while these allocations are no longer being reviewed, parties are still required to ensure that Medicare's interests are adequately protected. So as such, CMS did issue guidance within the reference guide that lists circumstances where a $0 MSA would be appropriate. There's 4 specific parameters, and for brief reference, those are, 1, where no future medical treatment is needed. You have a treating provider that certifies with a reasonable medical certainty as to same. 2, where there's a formal denial of responsibility by the carrier. 3, a judicial determination has been obtained, that rules that the carrier does not owe any additional benefits. And the 4th one being where there's a timely denial after investigation period. And that is really specific to an allotted statutory time frame. So, now that CMS has transitioned away from reviewing $0 MSAs, the burden of proof for compliance really rests entirely on the parties involved. So it's vital to maintain documentation to verify the basis for the zero, to minimize your risk. But as always, if you have a denied claim, if you're questioning whether or not it qualifies under any of these parameters, don't hesitate to shoot it over to us, and we'd be happy to review the claim to determine whether or not a zero is appropriate there. Okay, so for number 3 on this list, we're looking at amended reviews. So for amended reviews, these are where you have a request that CMS take a second look at an allocation where CMS has issued a determination letter because there's a material change in treatment since the date of submission, right? So one previous change is the amount of time required in between the date of submission and the date of the amended review request. And this has really sort of been a sliding scale since the inception of the amended review process. Most recently, the waiting period was 1 year post CMS determination. However, now there is no waiting period to turn these around. So, for example, you submit an MSA to CMS for review, which contains future medical projection for both, lumbar fusion as well as injections, because both of these services were listed as possible treatment options. But let's say 2 weeks after you receive what is now essentially an inflated CMS approved MSA, the injured worker has a follow-up visit where the treating provider states that the injured worker is responding well to injection therapy and therefore a lumbar fusion is no longer recommended. Well, you can take that medical record, incorporate that into a new MSA, turn that right around and resubmit immediately, so long as the new allocation amount is at least $10,000 or a 10% difference from the original CMS approved MSA. So the real change here, as of this last year, has been that CMS has been requiring that all medical records and pay histories from the original submission be included with the amended review submission. So not just the new records, which show a change in treatment. Now, when you have the same submitter, that's really not too much of an ask because that submitter should still have those records on file. I think where we've seen this create some issues is where you have a change of submitter when it comes time for the amended review, right? So then you're essentially at the mercy of trying to obtain an original submission packet from a different submitter. Not to say that, that can't be done, but definitely creates a little more challenges that way for sure. So staying on topic with MSAs, we'll change gears slightly as Scott walks us through how submitting an MSA to CMS now intersects with Part D or prescription drug plans in an entirely new way.
Yeah, thanks, Neha. So the whole process, as we've said, sending claims through Section 111 notifies CMS where there's a primary payer, also now notifying Part D plans where there's a primary payer, and where those funds, how those funds should be used. So last month, CMS began providing the Part D plans with up to 12 NDC codes associated with approved WCMSAs. So if you sent that MSA to the work comp review contractor for review and approval, and it gets approved and you have drugs listed there, you get a case control number assigned to that work comp MSA, that information is now being passed to the Part D plans. What that means is it gives the Part D plans the knowledge that there's a primary payer, that there's a work comp MSA set aside, that the money for the medications should be funded through that MSA. Also extends their right of recovery. They know, like I said, that there's a primary payer. They can either set up conditional pay of the drugs and seek reimbursement, or the Part D plans can introduce prior authorization requirements, point of sale requirements, things that may make it more difficult for the injured person to obtain the medications that they need due to their injuries. Remember, this applies to MSAs that have been submitted and approved. And again, that impact falls on the claimants. So it introduces a bit of a conundrum, right? Where submission of MSAs has always been optional. Many people have it as their normal course of action. They want to make sure it's been submitted and approved by CMS. But if it could potentially cause issues for the claimants, does that change your position on that? The volume of submitted MSAs has decreased over the last few years, for several factors, not to mention what Neha mentioned earlier about the work comp MSAs being submitted through Section 111. So we're likely going to see that trend of submitted MSAs to decline a bit through 2027 as we learn more of what CMS and the Part D plans are doing with all of this. Marty, want to fill us in on the LMSA rules?
Sure. Yeah. No. Thanks, Scott. LMSAs were scuttled, right? So it was over a decade. CMS had sort of toyed with the idea of creating regulations that would require the use of essentially a liability Medicare set-asides. This goes back to the old, what we would call the ANPRM, Advanced Notice of Proposed Rulemaking, from I believe it was like 2012, which was basically going to require, for lack of a better word, an MSA on every settlement involving a Medicare beneficiary, regardless of the amount of the liability settlement. And that was during the Obama administration. That was walked back, and then it was sort of reintroduced at some point over the course of the last 6 or 7 years, with a notice of proposed rulemaking, an updated notice of proposed rulemaking, which slowly was sort of turned off and then eventually was withdrawn. So at this point, there is no plan that we are aware of. There's no plan that CMS has that we're aware of to introduce or reintroduce a notice of proposed rulemaking around liability Medicare set-asides. And there's no policy on liability Medicare set-asides that's formal and written as it is in work comp MSAs. The only policy is actually, believe it or not, 15 years old. And that policy memo says that you should not get a liability Medicare set-aside in circumstances where the person will not need future medical treatment. That's it. It's the famous memo about nothing, right? So it's the George Costanza memo or the Jerry Seinfeld memo of LMSAs. But that memo is still out there. You can still find it. You can go. Good luck looking for it and tell me what it means. At the end of the day, there is no formal written policy from CMS with regard to LMSAs, and we don't anticipate that changing. So in some cases, right, these are, we've talked about the transformation here. CMS went from sort of guns a-blazing to do something with regard to LMSAs to really kind of, walking away from it and focusing far greater attention on the WCMSA process. And all of these changes here do have significant impact on work comp claims, but not on liability cases. Now, sorry, this last one, what hasn't changed, unfortunately, Neha, we still run into this challenge. These challenges when it comes to dealing with submitted work comp Medicare set-aside. So why don't you kind of speak to some of the things that unfortunately we haven't seen change and maybe in some cases have gotten a little bit worse?
Yeah, sure. Thanks, Marty. So we did, we brushed upon this earlier this year when CMS came out with its, annual data regarding, work comp MSAs. And what we see from them is that they continue to, stay within their sort of conservative approach in their allocations from, the difference that we've seen from what is submitted to what is kind of pushed back. We do feel like this is something that has contributed to the increase in the non-submit or evidence-based allocations that we're starting to see, because there's sort of a very, black or white way of reviewing these allocations when they come through from CMS. So there's not really a realistic, holistic look or reasonable look when you're looking at, okay, well, this individual could have a spinal cord stimulator and lumbar fusion and be taking, 5 oxycodone a day. Well, projecting that out for the claimant's life expectancy isn't reasonable, but the fact that it's a possibility, Medicare wants to make sure that they're covered for that. And so we're seeing these really inflated allocations come back sometimes that are not only not reasonable, but also sometimes just, quite dangerous and may not even be beneficial for some of these injured workers. I don't know if there's anything else on that with you that you'd wanted to add, Marty.
Yeah, I mean, my biggest thing is exactly sort of like what you said, Neha, which is that there's a sort of a bright line test that CMS imposes in these cases, maybe for the sake of making the review easier, maybe for the sake of creating uniform rules countrywide. But basically, it's there's a chance that a person is going to need treatment. They expect it to be included in the allocation, and I don't think that we, as people who handle claims or resolve claims or counsel people who resolve claims, would ever say, "Hey, yeah, well, because there's a chance that the person might need something in the future, you should just buy it and give it to them." Right? You wouldn't do that in real life. Like if your kid said, "Well, in the, I might need this book," sure, you might buy the book, but that's really the extent of it. You're not going to go buy a car, and that's the amount of these things, or a house in some cases. If it's spinal cord stimulator, well, they might need the house, so let's go buy the house for them. That makes no sense. Yet that's the way that CMS requires people to in some cases approach this. And ultimately, if it says, "Hey, you might need the house, so we'll just buy you the house," you're just not going to buy the house. You're just not going to settle the case, right? So it does have real world impact. The impact is to beneficiaries who can't go ahead and settle their cases, where if the person wasn't on Medicare, they'd probably be able to settle that case no problem, right? The impact is obviously to employers who can't settle the case and have to leave the case ongoing, and just those claims continue to clog up. Frankly speaking, the work comp docket, right? So at the end of the day, that's the real impact here, and that has not changed. We have not seen that. And pointing out what you had said earlier too about submitting cases, and Scott, with like the idea that maybe people would submit fewer cases. One of the things, and we'll talk about in a few more minutes, is what we don't really see published by CMS is the delay, right? Because well, we're having to go out and gather information on stuff that's not related to the underlying claim. That's resulting in delay in the resolution of the case, and maybe the case just sort of sits with CMS and never gets resolved. So those things haven't changed. We'd certainly love to see them focus a little bit on making it easier to resolve some of these cases. So I think with that, I think we can go on to the next slide and wrap up and talk about opportunities, right? So first up, updated ORM termination guidance, right? So back when Section 111 started, there was no easy way to simply terminate ORM when the claimant just walked away, right? Or the claim just itself walked away, right? So you would have to terminate ORM after it's been reported only when the person died, when the claim settled, or when the claim converted to denied status. And then CMS changed that, and they modified it so that if there were 5 years with no treatment and less than $25,000 in medical spend, then CMS would in fact allow you to terminate ORM. Well, that's great, but there's a lot of cases that are still reported as ORM set to Y, where the person's no longer treating, the claim is resolved and closed, and yet there's no ability, because perhaps the person hasn't gone to the doctor in a long time, and you don't want to send them back to say, well, we want to terminate ORM in this particular case. So that's resulting in something that's negative for the beneficiary, and that's negative for claim staff, and that is that providers have the misunderstanding and believe that company X is responsible for that person's medical treatment, and company X should be where they go, and instead the provider basically denies coverage or denies the ability for that person to treat. So we would like CMS to modify this. Certainly that's a pretty common industry position, for CMS to make it easier to terminate ORM and to rely upon the good faith of the insurance community. We've been reporting these claims in good faith for the last 16 years. And, we can continue to do so. And of course, if the person does come back to us for treatment, then we can simply remove the ORM termination. So updated ORM termination guidance would certainly help make things easier. It's a big opportunity for us. It's a big opportunity for, when I say us, the community, but also for the beneficiaries and providers, and just making it simpler for everybody. And I know, Scott, this is one that we've done a lot of research on this, and there's still like thousands of claims that we're aware of, at least tens of thousands of claims that are sitting at ORM, and they've just because they've had more than $25,000 worth of medical spend, you can't terminate, right?
Exactly. Yeah. So they're just sitting out there waiting for any updates. There won't be any updates, right? There won't be any new ICD codes, or just, open ORM sitting at CMS. Again, causing potential issues downstream with the claimants trying to get benefits, trying to get medications, or whatever it is. And yeah, there's no end in sight on those claims. So many of them.
Right. So it's just an opportunity for CMS to clarify things, make things easier, and hopefully improve the process for everybody. And don't forget, I mean, if it's the case that that claim is reportable, then you should be querying it too. And there's a lot of cases that are being queried right now because there was $30,000 worth of medical spent in 2016 on a case. Well, maybe you shouldn't have to report that claim, right? Or there are organizations that are querying claims like that, as they really should. They're following the rules as drafted by CMS.
Yeah, I'll just add, it's important to note that these are reportable claims, right? They do qualify for reporting, but what's the opportunity to terminate ORM? So don't think to yourself, oh, these claims, I'm not even going to worry about reporting them to CMS, because that could be a CMP instance, right? Late reporting of, or no reporting of acceptance of ORM, thinking you just want to get out of having claims sitting out there. So don't go down that thought process.
Yep, absolutely. Okay, next opportunity here, more appropriate WCMSA review processes. So we just talked about this, but CMS really does have, I mean, we've been doing this for a very long time, right? I shouldn't say how long, right? Neha's been doing it for 3 weeks, right? But actually, she's been doing it for 15 years, and she started when she was 3. But at the end of the day, we've been doing this for long enough where we have not seen CMS move the needle at all with regard to the review process. And that's a real challenge, right? So it's always been the case that if there's a chance that you're going to need treatment, then CMS wants it to be included. It's always been a case that if the person was on a drug that they should only be on for 30 days, and for whatever reason that showed up in the pay history, they want that priced out for life. There's no clinical foundation in that. And so now that the claims have to be reported to CMS with the MSA amount there, it creates the opportunity perhaps for CMS to track that information a little bit better and to modify those review processes so that they can make it more of a dynamic resolution on some of these cases that allows people to resolve their case and actually make sure that CMS does get something. There's no requirement that you submit these cases to CMS. The requirement is that you not shift the burden for post-settlement treatment onto the Medicare program willingly and knowingly. So Neha, I guess that's a real question here is, do you think that CMS is ever going to do it, or are we in a position where this is one that we can, shout from the rooftops, but, at the end of the day, CMS is not going to make the change?
Yeah, I mean, that's a great question. Like you said, this is something that we've been seeing for quite some time now. We see all of the issues that arise. We see all of the, settlements that get held up because of the, files that are either stuck in development or come back with an absorbent, counter hire. We have seen, I think, I guess some silver lining is we have seen an acceptance of, evidence-based, allocations. I know here at ECS, we've submitted several evidence-based allocations and have had some great success with those. So there is an openness to, looking at some of those different guidelines and the way in which, treatment can be provided, but it's hard. And I think, like you said, now we have mandatory MSA reporting. It's sort of another way of keeping tabs or keeping their eyes on what's happening, how things are being funded. You could tie in the Part D sharing that we have now. So when it comes to prescription drugs, this is sort of a scary aspect because, like you said, if someone's on a high-priced medication, they're going to price it out for life. It's not realistic. It's actually, it can cost carriers a lot, and it can cost a lot as far as, the health and well-being of the people that are actually on these drugs too. So it'll be interesting to see how it all plays out, but I don't know. I don't know if there's any end in sight with that right now.
We can hope. So the next one up, so CMS has done a great job of publishing Medicare set-aside stats for us every November. And so that's how we know that the number of accepted MSAs or approved MSAs has dropped the last 3 years, right? So it went from about 15,000 a couple of years ago down to about 13,500 last year. We would love for CMS to publish information on development letters, right? Because what we don't see is the number of submitted cases versus the number of approved cases, right? So we can, if we know there was 13,500 cases that were approved by CMS, we know for sure there are more cases that were submitted because there are cases that are in development or abandoned by submitters or by carriers and claimants because of the fact that they just couldn't meet all of CMS's requirements. Similarly, we don't see really published timelines on conditional payments. We can certainly tell how much CMS's contractors made based upon their requirement to disclose that information. Ultimately, that helps us figure out how much they actually saved. But at the end of the day, it's hard for us to know based other than our own experience that, it's going to take on average 30 days for a conditional payment dispute to occur, right? So we would love for CMS to publish that and hold the contractors somewhat accountable. And that's a huge opportunity for CMS to shine a little bit of sun, as it were, on what the performance of the contractors is, because it has real world impact to individual people, right? And their ability to resolve cases and get treatment. And then lastly on this list is just to address the Medicare Advantage liens collectively. This is a huge issue. We've seen, countless Medicare Advantage plans that basically, unless you tell them that your case is settling at this very minute, it can be very challenging sometimes to get the information that you need to resolve the case, right? So it shouldn't be the case that you have to essentially hold somebody hostage in order for a Medicare Advantage plan to think that it's worth their time to send you a letter that tells you that you will either potentially owe something or don't, right? And at the end of the day, that some cases is what's required in order to get the information. So these are challenges that we would like for CMS to provide guidance either to the Advantage plan or to provide a way for them to collectively help resolve those cases, and to provide a process that is more than just go to that particular Advantage plan and hope that they can be bothered enough to give you the information. Certainly, we have processes to make these things happen quickly, but at the end of the day, it's up to you to understand or us to understand how each of those plans behaves. So with that, I think we have a few minutes left. Certainly, I know that we probably have some questions that have come in. And Adrian, I'm going to turn it over to you and ask you to be our MC for questions and concerns.
Yep. Thanks, Marty. So we do have about 3 minutes to answer some questions. If we don't get to your question, like I said, no worries. We will follow up and answer it via email. So our first question is back to you, Marty. This is from Dorothy. And she says, in Texas, we are running into reporting for certain injury codes and then receiving a conditional payment letter for treatment of dementia or cancer, and we are having to respond. Does CMS not look at the accepted diagnosis provided at the reporting?
It's a great question. CMS is supposed to utilize the information, and their contractor typically is supposed to use the information to try to narrow down, and it's to their benefit to try to narrow down the proper codes, because it reduces the volume of disputes and appeals that they face. Oftentimes at the conditional payment notice stage, which is the first stage, which is informal, the contractor will just spam you a notice. So you can have really, really disconnected codes showing up on those treatment forms. And our recommendation is to address them immediately within the first 30 days, certainly, in order to prevent the possibility of going to demand. It's a real problem. To us, we look at it as a complete waste of time and effort, and if it's a major inefficiency, and we have seen it. But unfortunately, Dorothy, I can tell you that you are not alone.
Great, thanks, Marty. And then the next question is for Scott. This is from Kimberly. I just wanted to clarify on the NOINJ. Claims without true medical components, mental anguish, pain and suffering only, etc., can now be unreportable versus no INJ.
No INJ.
Yes.
Yeah, great question, Kimberly. The answer is yes. So liability claims, no INJ used to apply if there was no true medical components, no injury to the claim. But now, as of this rest in peace, no INJ concept, those claims are not reportable at all. If there's no medical component on a liability claim, does not have to be reported.
Great, thanks, Scott. And this question is for Neha. This is from Michelle, and she asks, will CMP notices be delivered go paperless?
That's a good question. Yeah, I don't believe so. Is that correct? The information that we have gotten is that all CMP correspondence would be mailed to the RRE's authorized representative with a copy issued to the account manager. So the sort of pro tip that we've been sending around is just to make sure that for all RREs, make sure that you verify your profile report, make sure that your contact information is current. They've been very clear to say that failure to confirm that all contact information is accurate is not going to be an acceptable defense for CMPs. So that's the way those notices are going to go out. Just of note, they've also made it really clear that they will only be sending notices if there is a potential for noncompliance. So make sure your information is accurate and just look out for those.
Thank you for listening to this episode of the ECS on MSP podcast. We look forward to joining you next month for our next episode. For the latest updates and educational content from ECS, please visit our website at examworkscompliance.com. See you next time.